Ladies and gentlemen, it is a particular pleasure for me to chair this interesting session on TCT Asia Pacific 2022. My co-chairman is my old and respected friend, Dr. Takashi Akazaka, one of the pioneers of coronary physiology in Japan. We have a meeting with outstanding speakers and panelists from all over the world, and we have a challenging program. Can I have my first slide? We have a hot debate about invasive versus non-invasive FFR measurement. Next slide. At first, we will talk about the different varieties of FFR. The first presentation will be done by Young Min An from Seoul, from Upsan Medical Center in Korea. And of course, I take the freedom now, and that is a little bit challenging, to mention already some of the strong points and the concerns of the different issues to be discussed. The strength of FFR is, of course, that it is a gold standard. It is extremely well validated in all possible groups of patients, and it clearly improves outcome. The concern is the need for the hyperemic stimulus, adenosine, which is completely harmless, but gives naughty chest pain in many patients, and is expensive in some countries. To overcome that, the IFR and the non-hyperemic pressure ratios were invented with, of course, the strength that there is no need for adenosine and it can be done quickly. The concerns are that it has been shown to be non-inferior to FFR only in studies with low-risk populations like defined flare and sweetheart, and that in high-risk patients there are often false negative patients, particularly young patients with proximal severe lesions in a large coronary artery where the resting gradient may be low and the hyperemic gradient may be high. And of particular interest, there is a high mortality in the IFR group. Next slide. And the 2-year follow-up of the defined flare. You see here that the mortality rate at 2 years was 1.9% in the FFR group and twice as high, 3.8% in the IFR group, which is as high as the mortality in the angio-guided group in the much more complex FAME population. Xavier Escanet, also one of the pioneers in Euro in this field, and also one of the experts in microcirculatory disease, will further discuss this. Next slide. Then we will continue with the quantitative flow reserve with the obvious advantage, as will be demonstrated by Dr. Bosu, that there will be no wiring into the coronary artery itself. Still, it is an invasive procedure, but of course it is cost saving. The concern is that much of its validation has been done in favorable anatomy, and that we are a little bit afraid of a kind of same as appointment around the corner as we had with QCA in the late 80s. Finally, the CT FFR will be discussed by Bon Kwon Ko. He developed this technique in Asia. The strength is that it is indeed completely non-invasive with a very high sensitivity. Next slide. You will hardly miss any patient, and this is one of the most impressive slides I have ever seen. This is the platform study where 2 groups of patients presenting with chest pain at the first aid department were randomized either to undergo directly invasive coronary angiography or first FFR CT. The left bar is the patients who go direct angiography, and next slide, you see that about 30% of these patients had severe coronary disease which needed revascularization. In the group who was randomized to FFR CT first, that is the right bar, the number of patients undergoing invasive angiography was only 40%, but the number who had severe disease was again 30%, exactly identical to the first group. So that means that actually not a single patient with serious disease was missed by FFR CT. Next slide. And that means that FFR CT indeed has the promise to be applied as a gatekeeper and can extend coronary CT scanning to a much larger screening device for large populations. Bon Kwon Ko will tell us about that. Then finally, at the end, we have a very distinguished panel, next slide, consisting of Kevin Bainey from Alberta, Edmonton, Canada, my countryman Joost Damen from Erasmus University in Amsterdam, Neil Johnson, doesn't need any introduction, University of Texas in Houston, Dr. Chen Xian Tu from Jiao Tong University in Shanghai, and maybe if he has joined us, Frederick Zimmerman from the Katharina Hospital, who published the FAME 3 studies recently in the New England Journal of Medicine. It is with great pleasure now that I give the word to my friend Takashi Akazaka to announce the separate speakers.
Thank you, Professor Nico Pyle. Ladies and gentlemen, it is really my great honor and pleasure to be able to chair this session. So I would like to introduce the next speaker. Thank you, Nico, the wonderful introduction. So next speaker is Dr. Jung-Min An from Asan Medical Center, Korea. His talk is entitled FFR, It is Standard. Dr. An, please.
Thank you, Dr. Akazaka. Nice introduction, kind introduction. My topic is FFR, it is a standard. So the guideline already mentioned that the FFR and IFR are recommended to assess the intermediate stenosis. There's a class 1A recommendation in ESC guideline and last year ACC/AHA guideline. Another important concept is if FFR is negative, no benefit. So recommendation 3, don't do that. I think it is very important for the FFR concept. Initial studies, the Nico made the FFR concept based on the very sound animal studies, and subsequently he made a cutoff value 0.74, the inducible ischemia and non-inducible ischemia. This cutoff value was validated against the 3 non-invasive functional studies. So initially, I think FFR is on a physiology index to detect myocardial ischemia. Look at this graph. The patient number is small, 45 patients, but I think it is very interesting that less than 0.75, one over three, the non-invasive functional study positive. So less than 0.75 in this study, positive predictive value is 100%, but the negative predictive value is also very high, the 88%. So cutoff value 0.75 is a very good physiology index to detect myocardial ischemia. Thereafter, the many studies show that the cutoff value of FFR is between 0.75 0.80. So FAME trial investigators increased FFR cutoff value up to the 0.80. So the subsequent trials, FAME2 trial showed that if FFR is less than 0.80, the piece, even in the stable angina population, coronary vascularization is associated, reduced the urgent revascularization. So I think stenting is justified based on the FAME2 trial. In addition, the default trial nicely demonstrated that if FFR is more than 0.75, contemporary cutoff value more than 0.80, default is very safe up to the 10-year follow. So initially, I said initially the FFR cutoff value was validated against non-invasive functional study, but we thought that could it be validated against the clinical outcomes? So we gathered 5,800 patients, so 8,000 the lesions the FFR measured, and the deferred 6,000 lesion and revascularization 2,000 lesions. So we tried to make outcome driver revascularization threshold. So to look at this graph, the red line is the headed line of revascularized lesion. The blue line is the headed line of the deferred lesion. The revascularized headed line and deferred headed line intersected at the point of FFR 0.79 regarding the prime endpoint cardiac death MI target vessel revascularization. So this is a very supported the contemporary cutoff value of 0.80. Regarding cardiac death and MI, the revascularized headed line and deferred headed line intersected at the point of FFR 0.64. This cutoff value is very interesting because FAME2 trial, the mean FFR value is around the 0.68. So to reduce the cardiac death and MI, FFR should be less than 0.64. So contemporary cutoff value 0.80, based on these two graphs, could be the very important clinical index to decide the revascularization. So how about the gradient? Based on our registry, same registry, we evaluated around 600 patient deferred group, 600 patient performed group. 1-to-1 propensity score matching, 300 population, a gradient FFR, a patient with a gradient FFR, deferred lesion outcome, performed lesion outcome, similar up to 4 years. So gradient FFR overall outcome is similar between the deferred lesion and performed lesion. So clinical judgment may be important. In addition, the maybe imaging guided decision making may have a role in the gradient FFR. So using this kind of cutoff value, when we apply this cutoff value in the PCI practice, how much improve the clinical outcomes? The FAME1 trial, as you know, the up to 5 years, FAME1 trial random trial in multivessel disease population, randomly assigned to the FFR guided PCI and angio guided PCI. Up to 5 years, 1 year outcome show that the significantly decreased the risk of primary endpoint, but at 5 year outcomes, a p-value became insignificant, even though the FFR guided PCI group is associated with the numerically lower risk of MACE up to 5 years. More importantly, the both FFR guided group showed a favorable outcome with the reduction of stand number used 29.6%. So FAME1 trial up to 5 years nicely demonstrated that the FFR guided PCI is associated with a favorable outcome with less stand use. So we try to see this kind of trend in our registry, ASAM PCI registry. FAME trial was published in New England Journal of Medicine at 2009. So frankly speaking, in our center, before 2009, we never used FFR. But after 2010, we used FFR as many as we can if there was no evidence of ischemia prior to PCI. So during the 2010-2011, the FFR penetration rate is around 50% in PCI population. So what is the result of routine use of FFR in our center? Cardiac death, MI-TVR reduced by 41%. What is a major change in the PCI practice? Before routine use FFR, mostly angio guided PCI. After routine use FFR, in 50% of patient PCI population received FFR evaluation. Before and after, lesion number no difference, but the stand number reduced by 29%, very similar reduction with the FAME1 trial up to 5 year clinical follow. Which lesion territory? The RCA and circumflex territory, they received only the 40%, 41%, even though there is stenosis. Yes, it is very frequent that the RCA circumflex supply myocardium very small. So even though there is an angiographically significant lesion, stand number is less than less than angiographic evaluation. So please look at in detail about the clinical outcomes before and after routine use FFR death, no difference. Cardiac death, no difference. Non-cardiac death, no difference. Myocardial infarction significantly reduced after routine use of FFR, mostly due to periprocedural myocardial infarction. There is no safety signal in increased risk of periprocedural myocardial spontaneous myocardial infarction after routine use of FFR, even though more lesions, angiographic title lesions differed without stenting. Repeat intervention also significantly reduced, mostly due to the reduction of target vessel revascularization, target lesion revascularization. So based on our registry data, I think that the benefit of FFR guided PCI is primarily due to the reduced number of stents per patient and subsequent decreased risk of peri-procedural microinfarction and repeat intervention, stent-related complications. Then, what is the role in the post-ischemia era? You already know that the ischemia trial was randomly assigned to the conservative treatment, invasive treatment in patient at least moderate ischemia. Even though they treated they performed the revascularization itself, invasive strategy did not reduce the risk of all-cause mortality up to 5 years. So I think this trial told us that the no ischemia, no stenting. That means no FFR and no stenting. So this is my summary. FFR has a very sound scientific basis. Cutoff value 0.75 and 0.80 was initially validated against the ischemia test and clinical outcomes thereafter. FFR might be considered as a clinical index in revascularization decision-making rather than a simple physiology indicator of ischemia. FFR-guided PCI was validated in randomized trial and year-old registry, favorable outcomes with the less stent use. In post-ischemia era, FFR less than 0.80 would be a minimum requirement for coronary stenting, and revascularization of the stenosis with FFR more than 0.80 is never justified. Thank you for your attention.
Okay, thank you, Doctor, and a wonderful presentation. We will have a discussion in the final. Yeah. Okay, let's move on to the next topics. The next topics will be presented by Javier Escanet, my friend, non-hyperemic pressure indices, pros and cons. Javier, please.
Thank you very much, Takashi, and thank you very much also, Nico, for allowing me to be in this fantastic session. As mentioned, my topic will be non-hyperemic pressure indices. These are my disclosures, although I should mention also as a disclosure that, like in the case of Nico, who was obviously one of the fathers of FFR, was also very much linked to the development of the first non-hyperemic pressure ratio used in clinical practice, that is IFR. So both of us, of course, have, so lots of love for our children and the way that they have thrived in life. So let's start with IFR, because with IFR, obviously, it's the non-hyperemic pressure ratio more used clinically for longer. We learned quite a few things. We learned that in clinical trials that is non-inferior to FFR, as has been mentioned. It is faster than FFR, no patient discomfort related to adenosine, less PCI performed with FFR despite similar outcomes in the long term, more cost-effective, less crosstalk between serial stenosis, co-registration with angiography is available, and it has been tested also in high-risk subsets. Of course, the syntax 2 is probably one of the studies with the highest syntax, along with FAIN3 is one of the 2 studies exploring physiological indexes in triple vessel disease. Now, one of the signs that non-hyperemic pressure ratios have been adopted and that they thrived is the many indexes that follow the development of IFR. And, and in this aspect, industry typically takes a lot of validation and assessment before embarking into this. And you can see that there are many indexes now that are proprietary from different companies examining the coronary circulation, coronary stenosis without the need of hyperemia. So let's start reviewing all these indexes to understand the pros and cons, and also to see to what degree they are different from each other. First aspect is perhaps reviewing the sampling interval in non-hyperemic pressure indices. You can see that there are 4 indexes that are diastolic in nature, and there are 2 indexes that actually use whole cycle information in a different fashion, because PDPA uses average pressures over the cardiac cycle, while RFR uses instantaneous PDPA changes. So here you can see in more detail how the window for measurement is calculated, particularly in those indexes that are diastolic. Small differences between them, but as mentioned, you can grossly classify them as with a diastolic window or a whole cycle. The interesting aspect is that the spread of data that you get from these indexes is different. And this is a paper by Zhou Min Li in Circulation a long time ago based on a large study population. The spread for PDPA, that is based on, as mentioned before, on whole cycle average pressure, is smaller than IFR, RFR, or DPR. And this has implications. Particularly at the time, remember that lots of validation comes from very selected study patient populations. But when you go to real practice, you have to understand the impact that a small pressure drift may have in decision making. And that is where data spread plays a role. As you can see here at the left, you very easily understand that you have little data spread. Small changes in pressure calibration that you can see on the right translate into higher percentage of stenosis classification, particularly for lesions that are close to the cutoff for that particular index. In other words, FFR and IFR are more resilient than whole cycle PDPA to stenosis misclassification caused by pressure drift. But what we know is that the agreement is very good. When you have it in good study populations, you know that, as is mentioned, typically is data obtained with detail. You can see that the correlation between these different indexes with IFR is very, very good. How do they compare in terms of assessment with the detection of ischemia? And for this, of course, what you need to do is these head-to-head comparisons. Some of them performed with PET, like the study that you can see here. And basically, you can see that IFR, RFR, DPR basically have a similar diagnostic yield in diagnosing the presence of myocardial ischemia than FFR. This is something that you can see in the next slide, where you can see also the diagnostic yield of FFR compared with IFR and resting PDPA. And you can see that both in terms of the PET-derived coronary flow reserve as a reference standard or PET-derived relative flow reserve as a reference standard, they roughly are equal in identifying ischemia-generating lesions. What about the software? Is the same software for all systems? Well, here is where we can see one of the largest differences between non-hyperemic indexes. So you can see that, for example, pullback analysis, for example, it's only available for 3 techniques. And as a matter of fact, I will expand in this, only 2 of them has a sophisticated pullback analysis that allow its use to predict impact of revascularization, etc. Virtual PCI, the tool that will allow you to know what will be the final functional result of an intervention, subtracting the segment that is going to be stented, only available for the time being for IFR with co-registration with angiography, and also co-registration with angiography for the time being only available for IFR. This is what I was referring about the pullback analysis, which is sophisticated enough to make calculations. It is a software that actually addresses the fluctuations in PDPA, well, in intracoronary pressure ratios caused by the Venturi effect as the sensor goes through the stenosis. So you can see here that actually in this curve that you can see here, typically what you will have are ups and downs that will complicate your interpretation of the curve. And what this software, available for RFR and for IFR, will provide you a much better stairway like assessment of longitudinal assessment of the obstructive coronary artery disease in the vessel. Of course, the most sophisticated tool that we have now, which is addresses the problem of geographic mismatch when treating vessels that have been interrogated with physiology, is co-registration with angiography. the technique allows not only quantification of the length in millimeters of a particular segment, but it allows also the virtual extending feature. Like you can see here, we understand that if we extend this particular segment, we still have a residual IFR of 0.85, which of course is due also to the presence of this stenosis at the level of the left main. So if you want to achieve a good functional result, 0.95, you need to treat both stenosis. Other techniques have more rudimentary tools. This is the DPR system, and basically here what you can see, let me just go a bit faster, is you can basically make a spot measurement, and then as you perform your pullback, you will start getting a line of DPR values that goes to the very end of the vessel. But this system, of course, is not fitted with the same sophisticated analysis that we mentioned before for other indexes. Regarding the long-term outcome for evidence of non-hypodermic pressure ratios, all the information we have so far is for IFR in terms of prospective studies. Here you have the pooled analysis of the defined FAIR and IFR sweetheart analysis, in total 4,500 patients. These are the 5-year results of the IFR sweetheart study, demonstrating that at 5 years follow-up, basically the outcomes of patients in whom revascularization was guided with FFR or IFR is identical, basically. And if you go to high-risk subsets, I will mention then the Syntax 2 study, in which the IFR was used to make decisions in 75% of the lesions. The results, as you know, are outstanding at 5 years follow-up. And I can tell you also that only 1% of lesions that were deferred, revascularization was deferred based with IFR, had a revascularization every year. But there were other studies, retrospective studies comparing different indexes. Here you have IFR, RFR, and DPR, basically coming with a conclusion, like in this paper by our colleague today with us, Dr. An, demonstrating that there is no inferiority between making decisions with resting PDPA, IFR, DPR, RFR, or DFR. And finally, how useful are resting indexes in predicting PCI values? Well, one of the first things that was demonstrated is that the prediction that you make based on subtracting specific jumps in your longitudinal curve with IFR correlated very well with the results that were obtained after stenting these lesions. And this provides indirect evidence that actually the predictive value of IFR is rarely influenced by the intervention itself. Also in Japan, Dr. Hitoshi Matsuo and colleagues checked the ability to predict results of the intervention with other tools compared with IFR, and they came with the conclusion they are equally effective. But it is true that we are still in the area of predicting PCI results. We have uncertainties, and this is a good example that illustrates, in this case, in the terms of IFR, RFR, how you can be fooled in some occasions. This is a patient, complex patient, as you can see here, LCX, LAD, PCI, rotational atherectomy, LAD. There's multiple episodes for generating ischemia. And at the end of the procedure, the functional result with RFR seems to be suboptimal, while FFR shows a value of 0.86 that is acceptable. Now, I want you to keep an eye to this thermal dilution curve that was obtained simultaneously and look to the resting time, which is 0.24 seconds. Because in this particular case that was done by my good friend Lopez Palop, what he did is he repeated the measurements 24 hours later. And then he found that RFR had returned to normal values. And that was basically associated with also a longer resting mean transit time, meaning that In this patient, there was probably reactive hyperemia or adrenergic stimulation, adrenergic drive immediately after PCI that could influence a resting index. So, in the same way that with hyperemic indexes, we have the concern of acute microvascular impairment that may hamper hyperemia, we also have to be careful with resting indexes in whom, like in this patient, you may be fooled. And I think that there will be lots of evidence coming and helping us in deciding when we have reached a good functional result based with these indexes. With this, I would like to thank you very much for your attention, and I do look forward to your questions.
Thank you, Javier. The wonderful presentation about the non-hypoemic pressure indices. Please join the discussion finally. Okay, so let's move on the next talk. Less invasive QFR. It is next revolution. It will be presented by my friend, Dr. Bo Xu, Huai Hospital, China. Please start, Dr. Xu. Right.
Thank you, Dr. Akasaka. It's a pleasure to be invited again for the TCTAP meeting, and my talk is less invasive. So-called less invasive, or sometimes we call non-invasive, but it's a different concept. But let me show. Here's my disclosure. I think everybody are familiar with this slide because it illustrates how to calculate the QFR, and this is the early generation. We still need 2 imaging rounds with angle difference between 25 degrees. So after 3D reconstruction and the full hemodynamics, then we can generate the QFR without introducing hyperemia. This diagnostic performance of QFR was confirmed, validated in this FFR2 China study. It showed excellent agreement between QFR and FFR, and also excellent accuracy, sensitivity, and specificity. The online calculation of QFR. But today, in our daily practice in China, we already start to use the mu-QFR, the new generation. A lot of key features, single angiography view, bifurcation analysis, or side branch analysis. This because AI-powered system, then the analysis was much shorter, within 1 minute. You can do myocardial bridge, and to me, most important, most interesting is a strain analysis to test the plaque vulnerability, which was probably one of the exciting things in the future. And also, by using mu-QFR, you can use you can do angiography-based microvascular resistance. Then we can investigate this field in the future. Today, I'm going to cover mainly the FFR3 China. This large evidence is investigator-initiated, shamed control, blinded randomized trial. The patient who meet all inclusion and not be any exclusion will be randomized. But actually, one of the most important steps is the prior randomization. The operator in the cath lab must declare, identify the target vessel intended to be treated with standard angiography guidance. Then, a total of 3,830 patients will be randomized to QFR guided strategy or angiography guided strategy. In the QFR group, QFR was measured in all coronary arteries containing any lesion with visually assessed diameter stenosis between 50% and 90%, and RVD greater than or equal to 2.5 millimeter. Then follow the treatment of cutoff value 0.80 QFR. In the angio group strategy group, the PCI was performed based on visual angiography assessment per local standard of practice. All the patients will be clinically followed up to 5 years. To me, how QFR guidance changes the strategy. This slide is the second most important data besides the primary endpoint. You can see actually before randomization, vessel intended to be treated was very well balanced between group. And after the randomization, the vessel actually treated of those originally intended were dramatically changed. You can see more LAD and less circumflex treatment. And in summary, the vessel actually treated of those originally intended 84% was in QFR group versus 95.7% in angio group, resulting patient with intended vessel deferral or unintended vessel treatment 23.3% in QFR group versus 6.2% in angio group, including deferral 19.6% and unintended vessel treatment 4.4%. So you can imagine this strategy change significant impact on the key procedure result. So PCI performed in 90% in QFR group versus almost 100% in angio group. And we also seen the less number of stent used, the contrast media used, shorter fluoro time, and procedure time in QFR group as compared with the angio group. However, PCI lesion success was similar and very high in both groups, and the residual functional syntax score equal to 0. That means functionally complete revascularization was 88% in QFR group, much higher than angio group, 82%. For the primary endpoint, you can see the two curves separated, the 1 year MACE separated since the first 48 hours, indicating a difference of periprocedural MI. And the two curves continue to diverge until 1 year. The Kaplan-Meier estimate of primary endpoint 8.8% in the angio group versus 5.8% in the QFR group, resulting in 3% absolute risk reduction and relative risk reduction 35%. If we further excluded this periprocedural MI, you can see these two curves are beautifully separated from the beginning until 1 year, and the event rate was reduced from 4.8% to 3.1%, resulting in 36% relative risk reduction. In summary, the primary endpoint, again, 5.8% was 8.8%, mainly driven by fewer myocardial infarction, 3.4% versus 5.7%, and fewer ischemia-driven revascularization, 2% was 3.1%. Interestingly, the reduction of myocardial infarction was seen in both periprocedural MI, 2.9% versus 4.2%, and non-procedural spontaneous MI, 0.5% versus 1.6%, all statistically significant. So how to use QFR to guide real-world PCI in the cath lab? I'd like to use a case to show what is the strategy. This is a typical three-vessel disease, a patient with a long diffuse LAD bifurcation and a focal circumflex, proximal RCA, severe stenosis, and multiple plaque in the distal RCA. So our questions are which strategy, PCI was cabbage, or if PCI, which vessel lesion to treat, or how to treat. So, so step one, if we calculate anatomic syntax score 24 according to current guideline, maybe cabbage would be preferred. But if we calculate a QFR-based functional syntax score, you can see 21. So probably PCI would be an alternative therapy for this particular patient. And according to our publication in 2020 in circ intervention, we can see around 6% of patients for whom cabbage would be recommended according to syntax score converted to a lower risk group, and therefore another treatment, that means PCI option may be preferred. So you can see our data. And the step two, we call which vessel lesion to treat. Our concept is a QFR consistent PCI. So you can see LAD, a baseline QFR, vessel QFR, 0.86, LCX baseline QFR 0.85, and RCA VASO QFR 0.64. So we decided to do LED and RCA, PCI, and the circumflex lesion will be deferred. So this our data, just a recent publication, your intervention. Clear, you can see PCI, QFR consistent treatment was significantly associated with improved 2-year outcome. And so the step 3 is how to treat. This is, to me, is very, very interesting and maybe a working way in the future. Calculate the virtue PCI, or so-called simulated residual QFR. For LED, you can see if we treat proximal lesion, then residual QFR will be 0.90. If we only treat distal lesion, residual QFR will be 0.64. If we treat both, then residual QFR will be 0.98. For RCA, if we treat the proximal RCA, residual QFR 0.96. If we only treated distal, 0.68. If we treated both, residual QFR would be 1. So according to this residual QFR, we virtually plan our treatment. Our decision would be treat proximal and the middle LED, then resulting in residual QFR 0.98. Then we'll only treat proximal RCA, will be very good residual QFR 0.96. In addition, 3D QCA data will help with the stem size selection. So this is also a recent publication from our group in the International Journal of Cardiology, show a good correlation agreement between residual QFR and real post-PCI QFR. And this virtual suboptimal PCI result, that means a residual QFR lower than 0.92 was associated with worse prognosis. You can see this data. So the final result is actually we put 2 standing in LED and 1 stand in RCA. The post-PCI QFR 0.99 in LED and the post-PCI in RCA 0.95. So in summary, in patient undergoing PCI, a QFR-guided strategy improved 1-year clinical outcome compared with the standard angiography guidance while reducing resource consumption. The simplicity and safety of QFR compared with wire-based physiological measurement should facilitate the adoption of physiological lesion assessment into routine clinical practice. And new generation QFR system will require only a single projection and it incorporates more automated process that could further reduce analysis viability and time. Thank you very much for your attention.
Thank you, Dr. Xu. Wonderful presentation. Yeah, wonderful result from a FAVOR 3 trial. Yeah, I enjoyed really very much. So the final presentation will be presented my friend, Dr. Bong Kwang Koo. Yeah, his talk is entitled CT-FFR. We do not need invasive angiography. Yeah, Dr. Koo, please.
Thank you, Mr. Chairman. Hi, everyone. I'm BK Koo from Seoul National University Hospital, and I'm going to talk about CT-FFR and to see whether we'll not need invasive angiography in FFR. 15 years ago, while measuring FFR in the cath lab, I was thinking about this possibility that whether there is a way to assess hemodynamics from the static images. At that time, it was like a crazy idea, but I don't know why, that I had an interest in this possibility to measure FFR from the static images without invasive procedures, without pressure wire, and without adenosine. So these are models extracted bifurcation segment from human coronary circulation from CT scan. And from this model, we tried to measure the FFR and wall shear stress with the collaboration with engineers. And these are the prototype of the models for post-stenting simulation for hemodynamic assessment. And all these were made almost 15 years ago. And later, we were collaborating with the engineers in the Hartflow and the Stanford University, and finally ended up with the success in measuring patient-specific non-invasive FFR using CT scan and CFT, which enables to assess non-invasive hemodynamic assessment or FFR-CT in whole coronary circulation, even for these small branches. So these are the management examples of current pathway. So in this patient, proximal LAD is 70 to 50% stenosis at this area. So we generally send this patient to the cath lab, similar stenosis, intermediate degree. So measuring FFR, and it was 0.74, so PCR was performed. But in contrast, this lesion, 70 to 80% stenosis, it looks more severe than CT scan, but FFR was negative, 0.84, so medical treatment was performed. FFR-CT, which is almost risk-free, non-invasive, and cost-saving pathway, if this is successful, would accurately predict the FFR value before using only the CT scan, for example, 0.74, if this number is reliable and reproducible, if we simply check whether this lesion is similar or not, and then not measure FFR and just do PCI. For this lesion, CT-FFR is 0.85, so this patient's no need of FFR and no need of invasive angiogram. So this will change the practice pattern, and beyond that decision or presence of ischemia or not, this strategy or this technique can be evolving to a treatment planning. So here is a case of quite complicated distal left main to the LAD ostium involving ramus and diagonal branches. And this is the case several years ago we did during the live demonstration. So the question is whether we can plan or accurately assess the post-PCI physiology with the CT-FFR technologies. So before the invasive procedure or before the live demonstration, we did several simulations, left main PCI only or the crossover. So according to this simulation, I fixed my strategy as a left main to LAD stenting, leaving these diagonal branch alone because the lesion is so long, diffuse with the long stent. So during the live demonstration, I did an invasive procedure, implanting 3.0 by 38 millimeter stenting, followed by high pressure adjunctive balloon inflation and POT technique. And the estimated FFR value after this strategy was 0.84, and the measured FFR at the same segment during the live demonstration is 0.85. So these cases all illustrate or suggest the potential that the CT-FFR or this technology can replace invasive procedure, including the FFR measurement. In advance, recently there was a case report of the successful coronary artery bypass grafting based solely on non-invasive CT. So in this 88-year-old female patient, CT was taken, triple vessel disease, and FFR-CT also showed a significant LAD and circumflex disease and borderline RCA. According to this CT and FFR-CT results, surgeon planned the bypass surgery with one internal memory artery to the LAD, Y graft, saphenous vein graft to obtuse marginal, and also the right coronary artery. So this is a results of the CT taken 1 month after the surgery, relieving of ischemia in whole coronary circulation. So this also showed the potential that this technique, CT and CT-derived physiology, can replace invasive procedures, including FFR measurement, even for patients with bypass surgery. So the question we have, do we not need invasive angiogram and FFR with the advancements of CT FFR? Some may say yes. But before we say yes, we have to check whether all these assumptions and conditions for these CT FFR or any image-derived physiological assessment are validated. Geometry, boundary condition, resting and hyperemic flow assumptions. We all know that these data are calculated from the general or average value, and there can be some mistakes in extracting the geometry from the CT scan. And we also know that the baseline flow condition and hyperemic condition can be changed individually and cannot be generalized. And that is the reason why in these 3 pivotal studies, which evaluate the diagnostic performance of CT-derived FFR in comparison with FFR, is the accuracy is around 80%. And in recently published meta-analysis of all published the CT FFR technologies, including heart flow FFR CT and all the other techniques, the average sensitivity and specificity is around 80 to 85%. So some may be happy, but from this results, you'll get to know that this technique cannot completely replace the FFR CT invasive procedures. And here is a daily practice data. As you can see here, when comparison between FFR and FFR CT shows that the wide scatter and per patient and per vessel agreement is 70 to 80%. So this may be enough as a non-invasive technique, but not enough to replace the invasive procedure. So the answer for this question is no. However, if you consider this terminology, CT-FFR, you may have some different insight. It is a combination of CT and FFR. So for the high risk attribute for patient with coronary artery disease, I would say ischemia is one element, and all these different plaque attributes can be assessed by the CT technology, and adding all these each components can increase our ability to predict the patient risk or selecting the treatment strategy. And also this technology can derive many local hemodynamics such as high wall stress and pressure gradient and delta FFR, which can prove the benefit on top of plaque characteristics and also per vessel FFR CT. Another beauty of this technology is that we can collect or measure all the detailed hemodynamic characteristics. And in our previous Emerald-1 study, we found that if the lesion has a plaque characteristics of worse in terms of morphology in hemodynamics, the risk for acute coronary syndrome corporate lesion will be almost 12 times higher than the control. And if you can expand this technique to the blood flow simulation, myocardial perfusion territory, and microcirculation, we can truly get the complete picture of coronary artery disease from the CT scan and CFT technology. So ladies and gentlemen, my answer to this question is not yet, but already. Thank you very much for your kind attention.
Yeah, thank you, Professor Koo. Yes, a wonderful presentation, and I appreciate all the presentation. Yes, we will have only 10-minute discussion time. So, are there any question or comment from the panelists?
And I would like to ask the commenters, and I see that also Dr. Bainey and Dr. Sieberman have joined, to keep it very short. Please give very short comments, then we can treat a lot of points. Who likes to start? Neil?
Okay, yeah, I like to start.
Please.
No, please go ahead.
Go ahead.
I was just going to ask a quick question, sorry, with regards to the utility of FFR. in the setting of acute coronary syndrome. I mean, I think that there's definite value in stable ischemic heart disease, given the fact that majority of the FFR studies are based on stable ischemic heart disease. A reflection a little bit about acute coronary syndrome and specifically STEMI relating to flower MI and the cost effectiveness recently published in Eurointervention.
Yes, but you should take in kind, Kevin, that in flower MI, only in 4% of all patients FFR was measured. And in all other patients, it was measured at a later stage. So I think this is completely not representative and cannot be compared with the earlier studies, which were done in Rotterdam and in Copenhagen. Maybe Joost can also say something about that. Joost, you are quite an expert in PCI and FFR measurement in STEMI.
Yeah, so that is correct. I mean, the percentage of cases in which we measure FFR in an acute setting is still relatively low, but I think could be improved. Thus far, the number of cases in which we do it, I think in routine practice is somewhere around 5 to 10%, and I think that has the potential to be improved. If you look at all the previous studies like Dynamic Prime Multi, CompareAcute, which demonstrated that a FFR guided treatment strategy in patients with multivessel disease can be beneficial, I think deserves to get a broader catch up in routine practice. But I think there's still a lot to learn and when to measure it, how to measure it, and there is specifically in this day and age in which the complete revascularization approach being either ad hoc or stage is not yet fully elucidated.
Yeah, one more question to Xavier Escanet. Xavier, you gave a very nice presentation and you mentioned the co-registration to analyze the artery. Recently, another technique was proposed called PPG. It was introduced by Carlos Collet from Aalst. Can you spend a few words on that?
Thank you. No, it's a very interesting technique that is based on longitudinal vessel analysis. Again, something that has been revived, the interest, you know, in a way, I believe also as a consequence of the introduction of non-hypodermic ratios. I mean, you know, we were one of the few centers performing FFR longitudinal vessel analysis that was described by you and Bernard many years ago, but most colleagues were using intracoronary adenosine, and that's the reason why probably it was not adopted. Now, the PPG index provides a very interesting way of quantifying the degree of focal or diffuse disease that you have in the vessel. And that has implications because there is growing evidence suggesting that PCI is particularly effective in achieving good functional results when you have focal disease, which, by the way, sometimes is difficult to ascertain only by angiography. So there is a disconnect between angiographic patterns of disease and functional longitudinal patterns of disease. So I think that that's a very interesting index, and I believe that we will hear a lot about the use of PPG in the near index. By the way, we are participating in a study, and this morning we were just performing one case.
Great. Just a single question to Niels. Can you comment on the mortality of IFR in the defined flare group?
Yeah, it's interesting to look at those. You know, we haven't seen the data published, I don't think, but certainly the presentations that have been given at TCT have raised the question of increased mortality in the IFR arm. In fact, this is something maybe I'll turn back to Jun Meng, who is, I think, trying to put some of this data together for a letter by looking at both the Sweetheart and the IFR groups. Jun Meng? Is he still there?
Jun Meng, you are muted. Can you unmute?
Oh,
yeah. Recently, I tried to gather the two random trial of defined flare and the Sweetheart trial 2-year and 5-year outcome data show that unexpectedly the IFR guided PCI group is associated with a higher mortality compared with the FFR guided PCI group. But the other outcomes regarding the myocardial infarction and repeat intervention, there is no difference. So I'm not sure if this is the true effect or just the by chance findings. But But even though we need the reporting of 5-way outcome of 2 random trial, I think.
No, we reported the combined data sets at 2-year follow-up at EuroPCR. We did not find any differences in any of the
that
outcomes.
was, of course, in the combined analysis, whereas the studies themselves were by purpose published as 2 separate studies to fulfill the 1A class phenomenon. So for that reason, I was somewhat surprised that the 2-year outcome was combined. But we can discuss about that later. I would like, because the time is almost over, to give a last word to Dr. Sheng Xiantu and to Frederick Zimmermann. Dr. Sheng Xiantu from Shanghai, do you have something to comment on what we have heard today?
Thanks, Dr. Powers. I actually have one question for all of you. As Dr. Ang mentioned that the ischemia study shows that standing a lesion with the FFR more than 80 is not spotted, not necessary. But Dr. Koo also shows that the plaque categorization could add another information there, which is also our own opinion as well. I think plaque itself would have let's say incremental value. However, now if you have a lesion with FR normal, so more than 0.80, and but with a vulnerable plaque, so what should we do next? I think this is the question that we also would like to hear from you.
Great, thank you very much. And then finally, a word maybe by Frederick Zimmermann. Frederick, you are also muted at the moment. Frederick was, as you know, together with Bill Fearon, the author of the FAME3 study. And maybe you can summarize the great value of FFR in the FAME3 study.
Yeah, thank you. So, so my question also on tree-vessel disease, and the question is to Dr. Koo. You showed a beautiful example of using FFRCT to treat or to guide the treatment of tree-vessel disease, and I think that's super exciting. As we know, with CTA, there's always a problem if you have too much calcium, and that's a lot, mostly the case in patients with tree-vessel disease. So my question is, with FFRCT, do you have a problem with calcified lesions, or how can you use it?
Yes, I think that's a very important and practical question. So calcium is the enemy of any CT-based assessment. But the several investigators, including us, are working very hard using IVUS and OCT as a reference. So as of now, we have difficulties, but as we are working very hard, and hopefully, I think we can define some solutions to fix this issue. But this still is a big problem.
Well, what I just wanted to hear, in fact, is that if you look at the outcome of the FAME3 study, there was no non-inferiority for PCI compared to CABG. CABG remains important, but the outcome of PCI in this study using modern stents and FFR was as good as the CABG group in the Syntax study, and CABG was even much better. So, in fact, what we did in 10 years is improve both the technique of PCI and CABG by at least 40% or so. That was really something to be proud about. Having said this, I would like to give the word back to Dr. Akazaka, because we have spent our time, and I would like to hear Dr. Akazaka to close the session.
Yeah, thank you very much, all the presenters and panelists, and especially Nico, who give us a wonderful introduction and a wonderful chance to discuss of the physiology. Yeah, here we have a world famous doctor in the field of physiology. So within us, there would be no discussion about the physiology, but I would like to say here, this session is a debate session, invasive and non-invasive, and each modality may have an advantage and disadvantage, and still non-invasive FFR is on the way to develop. So we have to have an additional study to improve the usefulness of invasive FFR, non-invasive FFR. I think that is at the moment my conclusion, and I really appreciate all attendees and the wonderful discussion. Finally, Nico, do you have a final word in this session?
Well, I just want to thank all of you. I have said enough during this session. Thanks again to all our excellent speakers, to the panelists, also to the organization of TCT Asia Pacific. Young men, please give my warmest regards to your mentor, SJ. He's a wonderful guy who did a lot for the interventional cardiology in Asia Pacific. Thank you very much. I close the session then. Thank you for all your presence and have a wonderful day.
Thank you.
Thank you. Bye-bye.
Bye.
Bye.
Bye-bye.